can see, which is extending from the upper clivus to the C3. Considering the fact that it might be approached from the behind, from the posterior approach, the surgeon landed up in just leaving so much of tumor tissue. So because he took this picture as his sort of guide to go from the posterior approach and laterally try to remove the tumor, which didn't work. Based on these, so many approaches have developed now. Transphenoidal, transbasal, transoral, subtemporal, petrosal, transcervical, use endoscope, microscope, whatever you use. These are the approaches, the routes through which we can go. Classical example, this is a lady, 17 years, and then she comes back to me again. She has now children who are now in college. So this lesion has now regrown, not in the same area, it has grown higher up in the upper clivus, involving the base of the skull more anteriorly. So this is again, now this is not a localized lesion. This is going to nooks and corners. So she was approached through a totally different approach. This transfacial approach, I've done 7 or 8 of them, very effective. And the healing is perfect. So use the help of your plastic surgeon friend who does a leaf-out osteotomy for you, and you just make a cut going through the maxilla, underneath the labia, and you can perform and open up, and it's a huge field for you to operate. So this is, we removed everything again, and all the lesion was totally removed to whatever visual extent. We used microscope, endoscope, both endoscopic assisted procedure in this particular case. So once this is done, this lady had again a perfect excision. She underwent again another radiotherapy to that area, which was a virgin area because this was not radiated earlier. And she again lived for another 2-3 years till she died of a second cancer. So this is what you can achieve. So totality of excision has to be achieved whatever way you want to. Involvement of the vital structures, proximity to vital structures, very important issue. So this approach, leaf-out osteotomy, maxillary swing, extended maxillectomy, might sound very ghastly. It's not so like that. They heal perfectly in 2 weeks' time. You have so many cases of head injuries who have got maxillary fracture, ligamentic fracture, they just heal. And you don't have to have any morbidity in this situation. You can even do a mandibulectomy. This is one of my old patients 30 years ago. She has this extensive lesion, only 6 nerve palsy, nothing else. Look at the lesion, extending right from the base of the skull to C3, 4. Just a simple leaf-out osteotomy, simple procedure. And then you have got a huge field, sorry, I'm going the wrong way. And you have got a huge field to play around. You remove everything. Look at the extent. This is 30 years ago. This lady went on to live for 16 years, just 30 years ago. So that's the way the things can work if you do a total excision. You have to be really radical. That's the only way you can have a longevity better than the literature, because literature says only average 9 years of survival in these patients. You can now have a maxillary swing. It's a very simple procedure. You take help of your ENT or a plastic surgeons. They would split the maxilla after a leaf-out osteotomy, and the whole field, it's like a huge playground in front of you. This is one of the patients where I showed my foolishness. I never examined the oral aperture of the patient before doing a transoral surgery. And after intubation, I found the mouth opening in this patient was only 1.5 centimeters. Now what to do? The patient is anesthetized. So I walked up to my ENT surgeon in the front OT. He just came, and in 10 minutes' time, made a just cut below the lip, split the mandible, and there's huge playground for me to remove, and he just joined it. In 3 weeks' time, everything healed. What about involving the vital structures? Look at this lesion. Not only in the clivus, it's going into the cranial cavity all the way around, and it's multilobulated. So here you have to stage. So this is the first stage, intracranial approach. Intracranial approach, you remove the posterior part of the tumor from the posterior fossa, and then you go to the transoral approach, and look at this picture on the right. This patient has radiotherapy. This lady, young lady of 24, is now surviving for 7 years. We don't see any recurrence till now. So this is what we are looking for. Excision, how easy it is. It depends on the texture, the architecture, and of course there are other factors which guide the excision lesions. Usually they're suckable, but they might have various septations. So this is where you might sort of falter. So you have to remove the septation by septation, go into each compartment and remove these lesions using microscope, endoscope, or whatever things you want to do. And here you see there can be bony shelves, eroded bones which need to be removed, and that's where you need to create space to remove these lesions. So these are the tricks of the trade. And sometimes there can be blobs hiding under the corner, and here the endoscope can be helpful. You just pull them out, and gradually these blobs can be excised. I'm not going to the full video of all these patients, but this is what you can achieve. And then at the end of the day, you have to be careful to see that you have removed every bit of it, whatever is visible to your eyes. Then the radiotherapy is definitely going to be the add-on which will add to the longevity of this patient and kill the remaining cells. So pure endoscopy is clean technique, but is indicated in selected group of cases. The radical excision is possible, and of course, pure endoscopy can give a total resection up to 65% in limited cases, not all cases. So what is the advantage of the pure endoscopy? Look at the way you can go to the nooks and corners. You can see the things much more better because you're very close to the lesion, and that's the advantage of pure endoscopic procedure. But these are again only, you can't just have the pure endoscopy with a limited approach in a lesion which is going here and there around the corner in different areas. You need to have a wider exposure. That's more important. This is my experience of 69 cases. And you can see 7 were incidental findings, clival 44, double compartment 17, 3 compartments 8, and these are all the procedures which are adopted for a complete removal.
Sir, you have 2
Recurrence were also treated. So, as you see, chordoma is a heterogeneous group of people. There's tumors. Radical resection is the first choice, definitely, and you should all go all out for it. Recurrence is common, and despite that, you can have another surgery. They can still live longer and go ahead. So orientation, understanding the radiology is very important. Sit with your radiologist. I would emphasize on this to the younger audience here. Navigation guidance, neuroendoscopy are advantage, but you need to first understand the anatomy very well. Plan your approach. If necessary, do multiple approaches, stage your approach, but just go for a radical resection if you really can. Thank you very much.
Thank you, sir.
Thank you so much, sir, for this very informative session.
Now the floor is open for questions. Before that, I would like to take comments from our esteemed chairpersons.
Very nice coverage by all the speakers, and started with Abida and Sukhdeep. It is oriented for 3D orientation of the anatomy for gross and micro. Then Dr. Anil has done nicely covering all the types of comparing with craniotomy, and Vijay has done a very vital new exopic transcranial skull-based surgery, new invention, and it will grow. I think it will be a big achievement later on. And Jayesh has done right, very pinpoint microscopic SOCA surgery indication and different. And Sir Ashish Pathak sir done the very well presentation of the chordoma of skull base with good results and experience of about 40 years. So he has done all the gross total removal of the tumor and the recent approaches. So all the speakers has done nicely, and we have learned a lot from this. Now the is open for question.
Any questions from audience? So, if you have no questions, then we can move on to next session. I would like to thank all the speakers for their crisp and content-rich presentations, and chairpersons for their guidance. And I invite speakers and chairperson to reach the backdrop area to receive their mementos as a token of gratitude. We can move on to next session.
Thank you, sir. So now we proceed to the session 2, that's skull base and CSF pathologies. Moderator for this session is Dr. Saurabh Dikshit, sir. On the chairpersons on the dais, Dr. Ashish Tandon, sir, Dr. Dandapani, sir, and Dr. Sudhir Pal, sir.
I hope so. Dr. Sudhir Pal sir is a bit late in coming, so I request Dr. A.K. Chaurasia sir to join us as chairperson and come forward on the stage. Now, over to the chairpersons for the session, and I welcome Dr. Ishwar HV for his talk on endoscopic versus microscopic CSF leak repair, indications and techniques.
Shall I start? Okay. Respected chairpersons and esteemed members of this audience, when Adesh threw this topic to me, it took me back to my years as a resident, preparing for an exam. How do you compare endoscopic versus microsurgical approaches for tackling CSF leaks in the skull? Well, when I prepared it, I borrowed the wisdom of others already who published on it, took my own experiences and prejudices. That is a disclaimer. When we look at the CSF rhinorrhea, it happens because of three reasons. One, of course, post-traumatic, which is the commonest. Second is iatrogenic, which is often our sins coming to haunt us after the surgery, probably a few days after the surgery or even few weeks after the surgery. And the third category is, of course, the spontaneous CSF rhinorrheas, which happens without any reason and increasingly associated with idiopathic intracranial hypertension these days. How do we treat that? One, conservative, you give bed rest, acetazolamide, etc. And then you can go for a transcranial surgery using the microscope or even with bare eyes, or go for endoscopic repair. Now, where is this leak coming from? The source to the nose. You have in the anterior clinic fossa, you have the cribriform plate, the ethmoidal sinus, the frontal sinus, and the sphenoid sinus as the usual culprits. In the middle fossa, the air cells in the temporal bone often leads to a kind of CSF rhinorrheas, and tegmen tympani, which is a thin bone where the dura gets ruptured and then leaks into the middle ear and then into the nose. In the posterior fossa, often it is the mastoid air cells which are incompletely sealed at the end of surgery, which leads to CSF rhinorrheas. Let's look at our sins first, the postoperative CSF rhinorrheas. Most often encountered in retromastoid surgery because of the invariable opening up of the mastoid air cells. The pterional craniotomy is not a lesser culprit. So, of course, the supra-broke mini craniotomy, often extolled as one of the best things for anterior skull-based tumors, comes with its own pitfalls, including CSF leaks in it because the frontal sinus is inadvertently opened or inadvertently inadequately closed at the end of the surgery. In the middle fossa, the pneumatized temporal bone just above the zygoma often is the site of C leak. And in the middle fossa as well as in the post-surgical situations, endoscope has less utility. Whereas in the anterior cranial fossa, where we have the leaks from the ethmoid, the cribriform plate, and even the sphenoid sinus, the endoscope holds the fort there. Now let's look at one of the crimes that we commit at the end of the surgery. We forget to close the small mastoid air cell here, and 1 month later the patient comes back to you with a leak. Then there are situations where there is a pneumatized mastoid air cells, above which is the tegmen tympani, which kind of thins out due to some reason which we still do not know, and which leads to a CSF leak into the nose. So both these requires transcranial repair. So you go back, open up and patch it up. First the dural rent with the muscle, fascia and glue, and then the next stage would be to pack the open air cells with muscle as well as bone wax until you're sure that no leak will happen. Okay, and now comes the pitfalls of doing a repair of the anterior cranial fossa using the transcranial approach. Leaks, especially in the site of the cribriform plate and ethmoid air cells. Here we have, you have to do a bifrontal craniotomy often, which means that there will be a lot of periorbital edema at the end of it. The eyes will be kind of swollen around. And then more importantly, Schongen and all had presented their series of patients who had loss of olfaction after surgery. This happens because of our inadvertent retraction of the frontal lobe, which leads to kind of an avulsion or partial avulsion of the olfaction. And loss of olfaction often leads to loss of taste sensation also along with it. So it is important that we avoid that to happen in our series of patients. For all these reasons, as well as for reasons like increased infection, increased recurrence, and increased rate of hospitalization, transcranial surgery for repairing CSF leaks in the anterior cranial fossa floor is less favored than an endoscopic approach. Let's look at the endoscopic surgery, which is like when I was being trained in the early 2000s, endoscope was just making its foray into neurosurgery. It was taking its baby steps, but now it has come to become the most important tool for repairing anterocranial fossa floor CSF leaks. More importantly, because of the availability of Haddad Basa Gastugi flap, which is actually a vascularized pedicle flap with a nasoseptal source, which is based on the posterior septal artery, a branch of the sphenopalatine artery. The advantage of which is you have a broad arc of rotation, you have extensive blood supply, and it can be customized to suit the hole that you are trying to close. But then there is always, and then more importantly, there is no external incision. One of the jobs that I used to do as a resident before the advent of endoscope surgery was, harvest fascia lata from the thigh, with leading to another wound in the leg, along with the wound in the skull. So the disadvantage of the Haddad flap, of course, is the rare event of flap necrosis, which is real, which can happen afterwards. Now, another adjunct that we often use for endoscopic surgery is lumbar drain, which is useful if your leak size is more than skull base defect is more than 1 centimeter squared. But then lumbar drain is an invasive procedure, has got risks of its own, including central herniation. So be careful. You have to have an ICU monitoring, and when you keep the lumbar drain, it indicated in large defects located in the anterior and posterior cranial fossa, especially and also indicated when the BMI of the patient is very high, pointing to idiopathic intracranial hypertension. Another adjunct that we often use in endoscopic repair of anterior cranial fossa floor CSF leak is, of course, the fluorescein dye, which improves the surgeon's confidence in identifying the site of leak and closing it off. So fluorescein dye also has come to occupy a center stage in endoscopic surgery as a useful tool to locate the site of leak and seal it off. And let me come to a small group of patients who come to us with idiopathic intracranial hypertension, where CSF leak is the point of presentation for that. When it happens, they present, what happens is first you address the CSF leak, but then there will be telltale evidence of presence of idiopathic intracranial hypertension in the scan, especially in the form of empty sella syndrome, enlarged periorbital CSF spaces, scleral buckling, etc. But then papilledema may not be there, so you may often be fooled to go into first the repair of the CSF leak, and afterwards it so happens that the florid signs of idiopathic intracranial hypertension can happen. In this case, you have to do an endoscopic repair first, followed by a CSF diversion procedure. The problem in doing the CSF diversion procedure in idiopathic intracranial hypertension is the small ventricle. So this can be overcome by the use of image guidance or robotic surgery, as it is done in few centers across the Western Hemisphere. Now, in our institute, we prefer the lumboperitoneal shunt for patients with idiopathic intracranial hypertension. Let me come to the advantages of transcranial surgery. I'm just summing it up. Direct visualization and stereoscopic vision and access, better control of, especially in recurrent and failed repairs, superior structural reconstruction with your own eyes and hands. Whereas endoscope has the advantage of lower morbidity, cosmetic superiority, shorter hospital stay, minimally invasive, etc. This is something, a head-to-head comparison between the two. You have hospital stays longer in transcranial repair, invasiveness is more in transcranial repair, recovery is slow, and defect handling of large and complex is better with transcranial repair. The success rates in anterior cranial fossa leaks, the endoscopic repairs stand far ahead of transcranial repair. So to conclude, endoscopic repair of CSF leak has eclipsed the need for transcranial surgeries in the anterior cranial fossa floor. Advent of the Haddad flap has simplified the procedure, especially in trying to seek another site of harvesting the fascia lata or some other source of tissue sealant. And microscope-assisted surgeries are important in middle fossa and posterior fossa leaks, and morbidity of open procedures is higher compared to endoscopic procedures. Thank you very much for your patience.
Thank you, sir, for your talk. And the house is open for questions. I would like to remind there is only 2 minutes for questions.
Are we taking questions?
What is your experience on use of fat you've used muscle and fascia, as you've told, but what is your experience on fat?
In our institution, we use fat as the first plug, followed by a Duragen or artificial dura or fascia, followed by Surgicel to hold it together, followed by fibrin glue. Okay, usually, only when there is a bone exposure, we pack that. Say, for example, you have opened the mastoid air cells, and then you go for pack the mastoid air cells with the muscle, usually the temporalis muscle or the posterior area muscles, and then seal it off with bone wax. That's what we do for ours.
Thank you. Thank you.
Thank you, sir.
Thank you.
Our next speaker will be Dr. Deepak Agarwal, sir, and due to some reasons he is not available here. So we have a recorded lecture of Dr. Deepak Agarwal, and he is connected on Zoom and will be available to take questions at the end of the session. So his topic is innovation in anterior skull base repair.
Since the introduction of endoscopy skull-base surgery in 1979, we have come a long way in our journey. And advances in skull-base repair, especially vascularized open flaps, have greatly reduced the incidence of the dreaded CSF. However, they have not eliminated. I am a firm believer that although endoscopic skull-base surgery is minimally invasive, yet it is maximally destructive. And there are large defects which we create which need more than the standard methods to repair. The development of the nasocentral flap by Haddad in 2006 revolutionized the endoscopic surgery and repair of the skull-base defects. However, not one speaker, I'm sure, would have spoken about the disadvantages of Haddad. There is a risk of necrosis of the flap, and the removal of mucosa leads to large defects which heal very slow. Also, there is a persistent problem of nasal crusting and feeling of a nasal obstruction. Added to this is the risk of almost 14% of septal perforation and collapse of the nasal dorsum. Various other techniques have been used by people like the gasket seal technique, which we all are aware of, as well as the bilayer button technique, in which the fascia lata in layers is put to prevent CSF leak. Besides the techniques, we have the standard filtering glue and the time-tested lumbar drain, which are used to prevent CSF. Also, there are various dural substitutes and other flap beside Haddad flap which may be used to prevent CSF. Now the biggest question is, why are we so interested in preventing CSF leak when most of the people around would say that in their experience, they have not encountered any significant CSF? Experience is a poor alternative for scientific knowledge. And if you look at the papers, there has been a grading for CSF leak with grade 0 being no intraoperative leak, grade 1 being intraoperative low flow leak, and grade 2 and 3 encompassing intraoperative high flow leaks. And you can see here that nearly 25% of the patients who are operated endoscopically will have intraoperative high flow leak, and additional 10.5% will have intraoperative low flow leak. So a total of 35 to 40% of the patients will have significant leak in the best of hands. This is a very interesting slide which is shown that even in grade 0 leak, people put in a lot of stuff, and as the grade of the leak increases, especially in intraoperative high flow leaks, everything from spongestin to fascia lata to fat to glue to bone is put in to prevent leak, because this is a dreaded complication if it translates into meningitis or other morbidities. One of the fundamental things which we need to understand is, in cases of intraoperative high flow leak, there needs to be a buttress from below. No amount of packing or suturing will help these intraoperative high flow leak because you need a buttress to prevent the pulsatile high flow leak. And for this, some people have tried to put in a temporary 4D catheter with balloon inflated, or inflatable mirrors have also been tried with good success rate. Other techniques like suturing, even for colleagues from SGPGI are doing suturing, and there is a non-penetrating clip device by the Japanese in which you can suture. However, suturing is good for low flow leaks. It will not prevent high flow leaks. There is another device by Medtronic, which is used by vascular surgeons to make a kind of a suture from clips. And there's a very interesting umbrella technique in which there was a device which was developed by the American cardiologist in 1974, and this is for cardiac septal defects. It's by the name of Antaxer PFO approval by Abbott Medical, and this is the cartoon of the device in which when we insert the guide wire, then the nitinol mesh is expanded on the inner side, and similarly a nitinol mesh on the outer side is expanded, and both of them then press on each other to really compress and clear the loop. It is interestingly available in India on IndiaMart, and I will show you the price. And a cadaveric study also has been done, although clinical uses I could not find them actually. So it is available in two sizes, 10 mm and 22 mm, which should be as per our defects should be ideal, with a price of between 30,000 to 50,000 rupees. The problem in countries like India is, and you can see here India, that although the care is affordable, it is low quality, and we need to somehow just cross this line into affordable, high quality healthcare. And for that, we need to take care of our complications in a better way, admit that there are complications, and see how we can do it better. So, obviously, there is new technology always required for such large defects, and we were also thinking, and we came out with this technique of having a very simple, easily available, I would say, sealant for this high flow intraoperative leaks, and that is the mini plates. So mini plates are available in every neurosurgical OT, very easy to, with different sizes, shapes, and to actually use as a buttress, I think there cannot be anything better than them. And this is a short video where I'll show you that how we do it at AIMS using this mini plates. And this was a patient with a large residual pituitary operated previously outside, very large defect. We took out the residual tumor. Obviously, we put in the fat graft, which is always the first layer. Then put in a layer of gel foam, and then we put in this mini plate. So you can see a 6-hole mini plate can easily go in. There's such a large defect, and then you put in a screw anywhere on the bone. You have to be careful that it's not near the carotids, but there is so much space around, and again I'm going in to show you, and it's the standard mini plate and screw, and I'm just screwing it on to one side. You don't need to screw it on both sides. As I said, the most important thing is to have a buttress on this, and we find a place and we just screw it there. We're tightening it, and once we tighten it, we can move it around, and I put in the fascia also, fascia lata, as a underlay under the mini plate. And once I do that, I will show you that I will move the mini plate over the fascia, add another mini plate, because that's so that you have full buttress of this, and then if you want, you can put another fascia lata over the mini plates, or you can put the Hadad flap over it with glue. So we put in glue, we put in the fascia lata, so the mini plates are completely covered on either side, and the vascularized flap over it. And the advantage is that there are various mini plates available, so very malleable, so you can easily bend them inside to make them fit the anatomy of the cellar defect. The insertion, because they are self-tapping screws, the insertion is also very simple. So this is my technique, and we have done over 11 patients. All patients had a high flow CSF leak, and although this is a short experience, there was no CSF leak in any patient post-operative. To conclude, skull base repair remains the Achilles heel of endoscopic surgery, and although Hadad flap remains the workout, it has its own limitations. For high flow intraoperative CSF leaks, which constitute more than 25% of all major endoscopic surgeries, we have to buttress the defect from below, and the mini plate or something similar is the way forward for this. Thank you so much.
Now we move on to our next talk. It is Clinical Approaches to Spontaneous CSF Leak by Dr. Suresh K.
Good morning, everyone. Spontaneous CSF leak refers to escape of CSF through a dural defect without any identifiable cause such as trauma, surgery, or tumors. It most commonly presents as CSF rhinorrhea or otorrhea. Historically, it is grouped with other causes, now recognized as a distinct entity. It constitutes 4% of all the CSF leaks. Etiological factors include idiopathic intracranial hypertension, which constitutes 70 to 80%. Chronically elevated intracranial pressure leads to dural thinning and skull base erosion, causing leaks, common in obese and middle-aged women.